Of course, you on, you rolling.
Okay, I'm rolling.
We got unlimited footage, brand new car.
I got a new car. Stamp. I'm like, how much space? I literally was thinking that. Like, how many gigs do we have?
Yeah.
Hey. Welcome back to More Than a Cervix Files, because you are more than your cervix. I, of course, am Dr. Wendy, aka Dr. Every Woman, and we are here today to break down barriers, to explore options when it comes to your health and wellness. And I hope that you will like, subscribe, share, and drop in the comments what you want me to talk about next. This today is going to be a really great topic where we're talking about sexual health, we're talking about sexual wellness. We're talking about what makes a person, more or less either interested in intercourse, but also like what causes pain and what can impact, pleasure, and like all of the things that can be done, or at least some of the things that can be done with regards to this. Because some people feel like, I'm broken, fix me. And it's like there are ways to fix the person's, areas, whether it be the vagina, the clitoris, like all the things, and even just your brain, because your interest is part of sexual health and wellness and libido. So today on More Than a Cervix Files, we are going to be talking to an expert on sexual wellness. We are going to talk to a urologist who deals with sexual health, who deals with pain with regards to intercourse, who helps people to feel better, to have more pleasurable intercourse. And we're going to talk about that in various stages of life as well, because the body changes. It changes with pregnancy, it changes with menopause, and so we want to really get into ways to improve like our pleasure and our, reduce pain, and that there are options when it comes to sexual wellness. So let's get into it.
All right. I am Dr. Fenwa Milhouse. I am a board certified urologist, and I am the co-CEO, co-founder of Down There Urology. Yes, I'm gonna rep my stuff.
I like it.
Own urology practice in Chicago. I am fellowship trained in something called female pelvic medicine and reconstructive surgery, or FPMRS, which is kind of very, very closely or almost identical to the subspecialty urogynecology. So I do see a lot of vulva owners in my practice. I also treat penis owners. So I love it because I treat everyone. And I do a lot of sex and sexual dysfunction in my practice, which is the crux of what we're getting into today.
Yes. I am Dr. Wendy Goodall McDonald. I'm a board certified obstetrician gynecologist from Chicago, partner in my practice women's health consulting, contributing faculty at Northwestern University, Prentice Women's Hospital, or Northwestern Medicine, Prentice Women's Hospital. I don't treat everybody. I don't deal with penis owners. If you got a penis, go to Dr. Milhouse. You know what I mean? Because that ain't it. But I do care for all those with vulvas. I do care for all of those with uteruses, humans with vaginas, I often will say. And so, yes, definitely excited to talk about this, excited to talk about sexual pleasure, sexual interest as it relates to pleasure and or pain, and things that we can do about it.
But yes, it's needed.
Yeah. I see, I have a lot of patients who come to me, saying that they want to have sex. And then one of the first questions I ask them is, do they have any pain with intercourse? And I think that's, and then if they say yes, then next question I have is, well, where do you associate the pain, or at what point of intercourse you associate the pain? Because I think there's a lot to discern there between, is it pain with penetration? Is it pain in the pelvis? And also these factors or these questions also wrap into how old a person is, whether or not they've been sexually active before, whether or not they've had any sexual abuse or assault, whether or not they have had children, are they pre or peri or postmenopausal? There's a lot to have and a lot to talk about with that. What is your experience with that discussion as well?
Yeah, you're right. I mean, similar to you, I see a lot of patients come in with the complaint of lack of desire, low desire, bothersome low libido. They want the want. And absolutely, there's a like a list of questions I then ask. But one of the top questions, or the first questions I ask, well, is sex pleasurable or is there pain? You know, a colleague of mine, Dr. Casperson, another woman urologist, I love what she says. She's like, is the sex you're having worth wanting?
Mm.
In the first snap, I know. Snaps, is it worth wanting? And okay, and I would say probably half of patients I see, at least, will say yes, there is pain. So then you have somebody who has low libido and pain with intercourse. And then then I already know that's going to be a longer visit, because we're going to have to tease out a lot. And I tell that person, listen, I need to focus primarily on the pain with sex first, and get that where at minimum you have the absence of pain.
Mm-hmm. At
minimum, you have the absence of pain with sex. I want you to have pleasure, but I will take the absence of pain at first. And then we can maybe go back and directly, hone in the libido, because that has to play. I mean, come on,
Yes.
right?
Yes.
If the sex hurts, you're not going to want it.
I mean,
you
what
can
in
want
life
the
do we
person all
do?
day long. And a lot of these, yeah.
Go ahead. Sorry.
Yeah. What in life do we do that we're like, oh, this hurts? It's yeah. So
Exactly.
like, I mean, and these individuals tend to love their partners. They love their partners. They have great relationships. They want to be physically intimate with their partners.
Yes.
It's just, it's these things that are so very common. And so then like it's a whole lot of like, I tell them, I'm going to be pretty nitpicky. I want you to describe the pain exactly. Where do you feel it? Is it in the vulva? Is it on the outside of the vulva? Is it in the vagina? Is there a certain side of the vagina? Do you feel it in your pelvis? Is it with the initial, rewind. I asked them what sex feels like, what sex looks like for them, because we can't just, this is heterosexual sex. We can't assume it's penis penetration. So I said, what does sex look like to you? There are lesbian relationships, we have to, and so it could be any kind of digital present penetration. You have to ask these things. So I never assume. And then I ask them, like, what parts of the activity make it hurt, and what does the pain feel like? And does it hurt throughout the whole entire process, or does it ease up? I mean, and all these questions help me try to narrow down what part of the anatomy might be the cause of the pain, or what, it kind of helps form my differential diagnosis. My differential difference, if it's like deep pain with deep, penetration, and it feels in the in the vagina, in the pelvis, versus if it's pain on the outside and initially with penetration, like that differential is different.
Yeah, 100%. I mean, yes. And to your point, sometimes it's just at the beginning, just at the first penetration, and then it will dissipate. And that's helpful as well. Because sometimes it's even a matter of lubrication or stretch. There's all kinds of components. And sometimes it's a matter of foreplay. I can't tell you how many people I talk to that I'm like, okay, do you do anything before? Y'all just jump right in? Oh, we just jump right in and then it hurts. I'm like, well, hold on now. I don't think we need to just be, what I'm saying? Like, not even warming it up a little bit, you know what I mean?
Like,
come on, get into it.
yes.
And maybe that's a difference too between, because I think that the sexual experience for many people changes as we age, right? So you're young and you're frisky and you're just like, almost like heated up before the car even starts, right? Whereas as we age, like, no, it's cold outside. You gotta let that car warm up before you pull out the parking space. You see what I'm saying?
Yes,
so
yes.
I think there's that.
Absolutely. 100%. You've got to warm it up. It's got to be lubed up, dry. Sex.
And even there's physiologic changes, right? Like the vagina elongates, at the time when a person is aroused. There's more blood flow, there's more stretch, there's more compliance. So there's also that like literal physiologic component that like the body changes with arousal, which may need to happen for many people before, if penetration is the goal, before penetration even occurs.
So you bring up arousal, and I break it down to patients, and I'll say there's think of sex as like 4 components. There's desire. I want to have sex. Okay. Or I think a fantasy. There's arousal. That's the both mental and physical response to sexual stimulation. Ooh, I feel more turned on and mentally, but my body's also responding. That could mean that you have more sensitivity in your clitoris or in your nipples. You get moist or lubricated. Like you said, the vagina elongates, it relaxes. That's all part of the arousal. That's prepping our bodies for the activity. Then there's the activity on the men's side of thing, or penis owner, it's an erection. Okay. It's the act of, blood engorging into the penis to get erect. For vulva owners, it's being able to take penetration, if you will. Okay. It could be dysfunction. And then there's orgasm. So there's 4, I'd like to tell patients there's 4 components, and you might have multiple dysfunctions in these components, and they may seem similar, but they are approached very uniquely. They have unique biological differences.
And also, just as we lay the groundwork for this discussion, and I think where I want to pivot next may be toward like, what do we do if we think that there is an issue? But as a kind of a groundwork statement, you mentioned those 4 components, and that last one being orgasm.
Yes.
I can't help but bring up another issue that people bring to me, or that people are troubled, when they come to me, and they may say, oh, I don't have orgasm with penetration, or I have never had an orgasm. And I just can't help but say, and tell me how you feel about this. Not everybody achieves orgasm the same way.
Yes.
Right? Like sometimes people will achieve orgasm from penetration. Some people will only achieve orgasm through clitoral stimulation. And that doesn't mean that they don't have fun or enjoy penetration, but they're not getting orgasm from penetration.
Dr. Wendy, the norm, by far the norm is that vulva owners can only orgasm through clitoral stimulation. We need to understand that is the norm. We should expect that. We should expect.
And the movies and the TV show, they don't say that.
They don't say that. And the porns and all that, they don't make it. The default is clitoral stimulation equals orgasm. That is by far the most likely response. So if you are a penetrator right now listening, you need to understand this. The default is clitoral stimulation is orgasm. If you're wondering why is an orgasm, clitoral stimulation is the default. 14% of vagina owners can orgasm with just vaginal penetration. So those
1-4, that is by far the minority.
Yes. So I'm like, I've had this conversation with patients like, okay, can you orgasm with other things? Like, well, I can orgasm by myself. Yeah, because the right pressure, the location.
Exactly.
I said, okay, why don't you try to incorporate that same thing during penetration? You can do that. You can try to incorporate that during penetration. Right. You can orgasm with penetration, but you're doing it because you are also including the clitoris in it.
Absolutely. Absolutely. Let me cast my child away, baby.
Oh, okay.
Downstairs. Not because you can't be here for this conversation, but everything you do makes noise. So I need you to take whatever you're doing downstairs, and if it's an emergency, come back up here because I got your back. But otherwise, be free, okay? Love you.
Not like they haven't heard you talk like this before.
Yeah, no, like sex we talk about, right? But so it's not that. It's just more so, bro. You with your chip bag is not gonna sit here and interrupt this deep conversation we're having. No way. Okay, so person who has an issue or concern in this space, they come to us, they tell us, and I think it's helpful, and I would hope you would agree, if people kind of like almost bring notes, or at least some mental notes about like when or what and in what circumstances, how often is the pain or discomfort or lack of pleasure happening, you know what I mean? Like, where are we with that? Because even some people, let's take it even further back. Some people will be like, well, I don't feel like I'm having sex often enough, or I don't have the interest as often. And I'll ask them, well, how often do you have sex? And I remember this one lady was like, yeah, like my husband thinks like, we don't do it enough, blah, blah, blah. How often are you having sex? Every like 3 days. And girl, you winning in these streets. Winning.
You winning.
No, what you talking about?
And that's no judgment to people who have sex often, but I'm just saying there are different barometers for what's often and what's not.
Yes. I do think there are the patients where you're like, maybe you just need to like be a little bit more realistic. You know what I'm saying? It's like the individual that comes to see me for erectile dysfunction and then come to find out oh yeah, I'm like, can you penetrate? Oh yeah, I can penetrate. Okay, can you last? Yeah, I can last. I was like, they're like, but I want to like
dysfunction.
But when I orgasm, then it goes down. That's what the body's supposed to do, sir.
That's
But
that's how it's designed.
That's how it's designed.
Yes, managing expectations.
Managing expectations. Like, okay, let's talk about this. Yeah, we are not genies here.
No.
Yeah,
so true. So true. So managing that, I mean, I think there's definitions of like sexless marriages where you have sex. I remember watching some TED Talk and it was like less than 10 times in a year, which, averages less than once a month, which some would say, well, that's still not sexless. You're still having sex sometime, but it's pretty infrequent. So I would, support that diagnosis. But so somebody who's having it infrequently, and if we kind of, hone in on, say it is pain and say it's pain, it's not deep inner pain where you're concerned potentially about like, ovarian cyst or something like that, which it doesn't always have to be that. I'm just throwing that out as a possibility. But say it is like penetrative, like at the space of the vagina. Like, where do you start with that? Say somebody who's not menopausal,
right.
But where would you start with that conversation of like, it is the vagina itself. It hurts when something tries to go in there.
So are you talking about, they're saying that it's as soon as penetration starts, like as soon as
well, then that's a good question. So is it like perineum, which is like right at the bottom? Is it like within the side stretching?
Yeah.
Can anything go in there? Can we use tampons? Can we put a finger or a toy? Or is it just with, and is it with certain positions? So I think you're right. There's more to even that discussion. I'm thinking, I guess where I was trying to go with that was something like, pelvic floor PT, or even, like something like that might be worthy of assessment to see like, are there pain points that might be able to be worked out?
I find so what happens is, especially if they've been dealing with painful sex for a while, almost all of these people will have pelvic floor dysfunction because it's almost like a reaction. It's the chicken and the egg, like what comes first. And a lot of times, sometimes it's the pelvic floor is the enemy, and like that's the sole thing. But a lot of times I feel like it's something else, and then the pelvic floor is on guard because it already knows like this hurts.
It's gonna hurt. It's anticipatory.
It's anticipatory. So your pelvic floor contracts, and it doesn't allow for that relaxation that is needed and necessary to allow for comfortable penetration. So a very common scenario, for instance, I'll give you is like a woman who has pain with sex. It's with initial penetration. It hurts with a penis, with a finger, with a tampon, with a speculum. It's, and it's, and they'll say, yeah, it hurts on the outside, but then the whole time it hurts too. It all hurts the whole time. There's no letting up. There's not just a position. And you go to examine that individual, and I'll take a Q-tip, and even the little Q-tip on the vulva will, like in between the labia, will hurt. And right at the opening, of the vagina, and it'll be, ooh, that hurts. Ooh, that hurts. That's not normal. That is not normal. And then I'll go and do a vaginal exam with my finger, and I'll feel the pelvic floor muscles through the vagina, and that's hurting them. They're like, it hurts. It hurts. That hurts. They feel tight like this, And so that's somebody who clearly has pelvic floor issues, pelvic floor dysfunction, tight pelvic floor, clearly would benefit from pelvic floor physical therapy, which, think of it like personal trainers for your muscles. It just so happened that these muscles are through the vagina, but these muscles are extremely important for us to enjoy sex, for also us to pee and poop, normally.
Comfortably, yeah.
Yes. Yep. The 3 Ps. I like to say piss, poop, and pleasure. But that person also, if I just focus on for that individual scenario, which is a very common one, if I just send that person to pelvic floor physical therapy, they're going to go through this pelvic floor physical therapy, which every single time the pelvic floor physical therapist inserts a finger or whatever is going to hurt because their vulva is a major part of it. So anything that's going through it is going to hurt. It's going to make the pelvic floor, like the progress that pelvic floor physical therapy can have, it's going to hamper that. Okay.
Yes.
It's going to, and so
So what do you do with that? Because it's like now it's almost maybe some vestibulitis in conjunction,
yes.
possibly.
Yep, vestibulitis. So the vestibule is that area between the labia minora, the inner lips, that houses like the opening of the vagina, the opening of the urethra. Yes, so I treat the vestibulitis primarily first. I won't send these patients to pelvic floor physical therapy right off the bat.
Okay.
I'll wait to get the vestibulitis better and then reassess the pelvic floor. Almost all of them end up going to pelvic floor physical therapy as well, because again, they've been so conditioned. But
Are we doing topical like hormones and stuff? Topical estrogen?
baby, yes, topical.
Even when they're premenopausal, we're going there.
Yes, most of them are premenopausal. Does it not? Topical hormones are for everyone.
Yeah.
Topical vaginal hormones are for everyone. Everybody is fair game. Everyone is fair game. Okay. And I explained that this is a vaginal topical. It is not going to offset
Absorb.
their disrupt. Yeah. So the vestibulitis patients, they need to do the topical estrogen testosterone cream. But the other important thing that they need to do is stop their oral birth control pill.
I saw you had put that article that just came out about vestibulitis associated with COCs, continuous combined oral contraceptives.
Yes. So I'm a big fan of birth control. Big fan. I used oral birth control for years and years and years and years personally. Fortunately, majority of oral birth control people on oral birth control will do well. But there's a minority of people who it can initiate or cause vestibulodynia and low libido, but forget the low libido part, the vestibulodynia. So it can contribute to that. And because it increases this thing called sex hormone binding globulin, which is a protein, eats up your free hormone levels. So anyway, we have to have them stop. And I'm like really serious about it. I'm like, I need you to understand this is like, this will, I really, really need you to stop these oral birth controls. And I will suggest as alternatives, IUDs, even if it's a hormone IUD, the hormone
that's different though.
Exactly. Yeah. You can talk to us about that, but even hormone IUD. Yeah.
So yeah, completely agree. And so IUDs, progestin only IUDs, similar to what you're talking about even topically with the vestibulitis, are really working locally within the uterus. They are thinning the uterine lining, they're thickening the cervical mucus. There's a small component of that progestin that may interfere with ovulation, but not nearly in the same way as a COC, a combined oral contraceptive, combined meaning estrogen and progestin, which to your point is changing that sex hormone binding globulin, which actually interferes with our endogenous testosterone and all of those things. And like you said, most people will do fine. I can't stress that enough. Most people will do fine. But I'm somebody as a clinician who never says never. I'll even tell my patients, I never say never. If you tell me you're having this experience with this, I'm not going to tell you, oh, that you couldn't have that. That couldn't be going on. Like it can be going on for you. Yep. And so if a person is having this symptom of pain, vulvar pain, and they're on a pill, you're absolutely right. That can be something that we need to change and affect, and that can affect those symptoms or improve those symptoms. Another scenario that people often have pain is like postpartum breastfeeding.
Yeah.
That's one that I usually am giving them the estrogen. I'm like, put this down there because it is a progestin dominant space, like in your whole body, different than the progestin only IUD. I can't help but stress this for people who may be like, but didn't you just say progestin was okay? Yeah, it is okay locally in the uterus, but when we're postpartum, when we are breastfeeding, that prolactin is running rampant. Like it's a hypoestrogenic state for our body, for our vulva.
I tell patients breastfeeding is like menopause for the vulva vagina. It's like your vulva vagina thinks it's in menopause. Okay. And so, yeah, I will I don't know about you, but I have and will prescribe vaginal estrogen to my breastfeeding patients. Yep.
Absolutely. Especially because, that's one of those times that you already aren't thinking about sex as much probably as you once were, because you have a baby. And so there's that. But then there's also the desire to get back into that sexual space, that sexual desire. And so don't lump on top of it pain too, where if you're now trying to have intercourse, it hurts or it's uncomfortable and it never was like that before. So I'm absolutely a fan of vaginal estrogens in that time and that space. I think there is maybe a component of it that our bodies are just trying not to be pregnant again right after having a baby. Like I think there's a physiological component to why we're not super that developed over the evolution of humanity, if you will. But that doesn't mean that we have to not reverse some of that or be able to still enjoy sexual experience while breastfeeding. So let's talk a little bit, because I don't want to belabor the point. I want us to get into some pearls, but I think people need to follow us both in order to get more from us, you know what I mean? And come see us if you need to. I want to get into postmenopausal people, because I think that's a little bit of a different space where we may need more than just the local activity, of the topical estrogens and testosterones. You want to speak to that a little bit, or what do you think?
Yeah. So postmenopausal women most likely will report lower libido. Okay, so lower desire, and some will also have vaginal dryness, which a dry vagina is not a happy vagina.
No.
A dry vagina is absolutely not going to be happy with penetration. So they often goes hand in hand, like dryness and also pain with sex.
Right.
And so these individuals, I love treating, number one, because they are kind of, some of them are like, oh, is this the end of the road for me? And I'm like, absolutely.
They think it's final.
Absolutely not. Yes, vaginal estrogen is queen in this circumstance. Vaginal estrogen is the gold standard. And it is safe.
Yeah, can't help but stress that one.
Safe. It is so safe. We give it to breast cancer survivors and patients. Okay.
Topical.
Vaginal,
or inserted. Yes.
Vaginal. Yes. Vaginal. I'm talking specifically vaginal estrogen. Multiple studies have shown it does not affect serum levels of estrogen, that it is safe to use in breast cancer survivors. It does not increase the risk of blood clots. So there's that, those people who get worried about that. It's safe to use in virtually everyone.
Absolutely.
So we are working, I know many societies have worked to get the FDA label changed, because the FDA label, the label does scare people still. It's just the same label they slap on estrogen tablets and the patches. But yeah, I'll put that person on that for their libido. And so that helps with the dryness and the dyspareunia, the painful sex. But these patients may still have bothersome libido, and the bothersome libido may not improve completely with vaginal estrogen, and it may not completely improve even with, if I put these on, if I'm treating
systemic
system, with systemic estrogen. I find that systemic estrogen, personally, this is my experience, is not adequate enough to treat the libido.
Okay? So you combine it with testosterone?
Yep.
I knew what she was going to say. I said, she's going to do both. She's going to do a little bit of this, a little bit of that.
So I have patients who are on vaginal estrogen patch, and testosterone. And some of them are they're like, oh, thank you.
It works. It does require you to be followed by a specialist, somebody who understands that those interactions can do it safely. I am all for it. I also can't help but mention that for those who, despite our comfort and reassurance, are still leery about estrogens or about hormones, there are, non-hormonal lubrication. There's other kind of like, and I don't want to call them band-aids, but other ways
in the vagina, if people are anti-hormone or just really antsy or whatever the case may be. I agree. You have to meet the patients where they are. So I'm not saying you can't be rigid and be like, well, this is the only thing, okay, no, this is what I prefer, but here you go. 100%.
Right. Hyaluronic acid. Like there's other ways to kind of at least moisturize to a degree. And again,
during intercourse, like do you feel like lube has gotten like it's like a shame? Like people are like ashamed to have to use lube. I'm like, why? It's normal. Grab
Me
that.
and lube, I
Yeah.
feel like lube the way I feel about lotion. Like, if I'm not ashamed of my ashy elbows or knees, why would I be ashamed about using lube? You know what I mean? Like, there's
Please.
no reason to think that just because it's not as moisturized at all times as I want it to be, that I can't use something that will replace or replenish that. Now, I do think having a good lube matters because some lubes are more
Yeah.
tacky. Some lubes can almost like, be in the way. But a
Yes.
good, like, slip and slide. Come on, what's the slip and slide? You know what I mean?
Yes.
Keep
I
it on
agree.
the bedside, just in case. You don't know when you might need it. Well,
Yep. Keep it by the bedside, please. Please. Yeah. I talk to my
keep it.
patients about lube a lot too. I ask them and I kind of like that's one of my like soapboxes.
And we
Don't get
all have our soapboxes,
too.
don't we?
Yep. Yes.
Nothing wrong with that. Well, I think this has been productive. What else do you want to add before we probably, wrap? I want to just make sure we both get our points out or our thoughts out, but I feel like we've covered a good amount of information
Yeah.
too.
Yeah, I want to add because we focused a lot on painful sex and dry vaginas, but for low libido, getting back to that,
Yes.
hinted to testosterone as a treatment option. That's obviously a hormone. It can be safely done, needs to be monitored, but there are non-hormonal low libido treatments. There are 2 FDA approved medications that are non-hormone, completely non-hormone. They work in the brain to increase dopamine and norepinephrine, which are like pro-sex, happy sex messengers. Addie and Vyleesi, those are their brand names. Generic is flibanserin and generic is bremelanotide. I have a great YouTube video, and I'm not even trying to plug this for myself.
No, plug it. No, plug it because this is important.
I have a great YouTube video about how to like getting your sex meds cheaper. And
Okay,
I think
good.
every single person, every single physician or person who treats sexual dysfunction or sees, or forget it, you see patients, women patients, men patients, or you have these issues, go watch the video. It's really not that long, but it is very like direct. It's like, if you want to prescribe Vyleesi, this is how you do it and get it for the patient for cheap. If you want to prescribe Addie, this is how you do it and get it to the patient for cheap. Okay.
That's huge because those meds, and this is the patriarchy speaking. I'm gonna just
Yes.
say it. Those meds and the estrogens, by the way, like they can
Yep.
be cost prohibitive for people.
Yeah.
You want to give them this thing that works, and people go to the pharmacy and they're like, I don't have hundreds of dollars to pay for this.
100%. Do not get a prescription for Addie or Vyleesi sent to your regular schmegular pharmacy down the road, to your CVS or Walgreens or whatever. It's going to be hundreds and hundreds of dollars, and it does not need to be. Does not. But you're right. If you don't know, you don't know. It's cost prohibitive, and then you just give up.
Yep. Yep. Because it's like, as much as you want to have sex, you want to pay your rent more than that. You know what I mean? Like, that's more important. So yeah, so that's cool. I would definitely will plug that for sure. I'm glad. What'd you say?
I said, now when gas is a bill, rice
Girl.
is like $15.
So I had my rental car because my car was in the shop, and I was like about to turn it back in, and you don't want to put more gas in it than you need to. I'm like, I'm just gonna put like $20 in it, because I'm gonna bring it back how I took it. Little $20 made that little needle move like this.
Little eighth of a tank.
They made give me 15 more. Like, what are you doing in these streets? Anyway, I was like, felt some kind of way. It transported me back into the day where like $20 was actually a reasonable, respectable amount of gas.
So I'm going to date myself. When I first started driving in 1990, I think it was 1998.
Okay.
A little car, whatever, but to fill my tank up, it was $10. I could fill it for $10.
Fill it up.
Mm-hmm. It was
10 will barely get you out of the red right now. That might not even get you out of the red.
Yes.
10 will get you maybe to the next gas station.
Maybe.
Maybe. Well, anyway. I appreciate you, my friend. I think this was really, really good. And I think we'll use this. The people will get a lot from this conversation.
100%. I totally agree. I love talking to you about this. Please follow Dr. Every Woman. She is amazing. She is so good.
The feeling is mutual. Dr. Milhouse on all platforms, on all the things. The feeling is so mutual.
What I really liked most about that conversation was that hopefully what you got from it too is that there are options, right? That we can, use not only medication, sometimes therapy, sometimes physical therapy, so mental therapy and physical therapy to improve how the body works, to improve how things feel. And I hope that you would feel comfortable talking to your healthcare provider about these options or asking for referral if that's something that you're able to get access to. But a lot of people don't even know that these, options exist. Pelvic floor physical therapy. Raise your hand if you've never heard of pelvic floor physical therapy. I know you got raised in the comments, but raise your hand. But I think that this is, hopefully going to just bring people to another level. So let me know what you thought. Let me know if you want to have another discussion about this or if we want to expand on this topic. Drop it in the comments, and I'll see you next time.